We have 7 million South Africans living with HIV to date. So weekly in South Africa, we have more than 200,000 new infections weekly. And these are amongst young women between the ages of 15 to 24.
People don't speak about HIV and AIDS because there's still a stigma attached to it. A lot of people still view it as it's evidence of you doing something that you're not supposed to do.
So, as you know, World AIDS Day is celebrated annually on the 1st of December. Now, on this day this year, Deputy President David Mabuza said, South Africa's journey and contribution as a country to the vision of zero new HIV infections, zero discrimination, and zero AIDS-related deaths has been long and difficult, but progress is being made. So today we discuss HIV and AIDS. We'll try and understand exactly what progress has been made, what challenges are we still facing as a country in the fight against HIV and AIDS, how far we are from achieving zero HIV infections, how we currently are dealing with this HIV scourge, and finally what the road ahead looks like. Now we'll be joined in studio by the Acting Chief Director HIV and TB from the Gauteng Health Department and the Interim Unit Director of the South African Medical Research Council's HIV Prevention Research Unit. We also have the CEO of the South African National AIDS Council, and HIV specialists, and 2 people living with HIV to share their stories with us. Now be part of the show by asking the panel some questions or simply just sharing your views with us. The number to call is Johannesburg 714-5861 or 5877. You can also tweet us at SABC Health Talk or simply just interact with us on our Facebook page, SABC Health Talk. So sit back, relax, and learn from this bumper show coming to you just after a short break. I'm Dr. Salome Daum, and this is Health Talk.
Finance Minister speaking last year was quite clear that one, he doesn't want a constant bailout of state-owned enterprises, including SAA. And then he also said there's no reason for SAA and we can get rid of it.
The one that people are talking about is the issue of privatization, but I don't think that privatization is within the horizon at the moment. But what I can say is the liberalization of the aviation industry may be on the horizon.
Talk to us about the share that the continent gets as compared to the rest of the world.
$1.85 trillion globally. 2.5% of that went into Africa in 2018. For us, the number one most critical issue in the energy industry of Africa is investment.
It's time for us to be real stewards of our resources.
We don't only show you what's trending, but also travel far and wide to find you hidden gems. We go deep into untapped territories, bringing life in its simplest form. Catch Trends Travel every Saturday at 8:30 p.m.
We believe that the fourth industrial revolution can change things for us.
We can do telemedicine. Now that means that over a long distance or any distance, I don't have to go and visit a doctor. I can actually see the doctor online.
In Africa, we don't have sufficient doctors. In Africa, we don't have sufficient clinics. It actually makes sense.
Wi-Fi and 5G technology formed some part of the conversation that took place right here.
5G, of course, has the advantage of better experience and also the high efficiency when it comes to the cost per bit.
We haven't issued spectrum in the last 10 years. We have 4G today, which we have had to harvest spectrum from other technologies to be able to get 4G, and now it's costing us a lot more money.
Many, if not most, small medium enterprise businesses are making technology their own businesses.
On Network every Sunday at 8:30 p.m.
Ivy Mabena from Soshanguve is living with HIV. It took losing weight and not feeling well for her to know her status.
So it happens that every month I used to buy new clothes. I can buy size 42, size 40, and then next month it will change to size 38 until I explained to them that no, I'm going to the doctor to check me because I wasn't on diet or anything. But my worry, I was getting thinner and thinner.
Ivy is also living with hypertension. To her surprise, after visiting the doctor asked if he can do an HIV test and ordered her to come back in a week's time for her results.
What I saw on that envelope, in that letter, I saw many positive. And after a few minutes, there was a silence in the room. And then, Ambulelare, Irene, Mama Ben, Kare. Positive, and I don't understand if I'm positive or what. I said that later, Ali Bala, yes, starting from today, you are starting a new life. You are HIV positive.
After finding out she is HIV positive, Ivy didn't waste time to disclose to her family, and her family have been very supportive. But like many, Ivy thought she was going to die.
Everybody was here. I felt like it was preview of my funeral. Everybody was here.
Ivy was diagnosed in 2007. She didn't immediately start treatment as she was still afraid and lacked knowledge. She only started treatment after seeing other people getting sick.
And he get check up on head to see those people Papa push the wheelchair, thinking I'm going there. Come hiring Christians, we are born again, and then I'm going there too. I'm going to mess up myself like them. I said, no, I can't. It's either I do the correct thing or I'm going there. So I started on the ARVs.
Pleasure Benjamin Ndlovu is also from Tshwane. He's an HIV activist and living with HIV. He found out about his status while trying to apply for a house bond as a new employee.
I was requested to go and apply for a policy. And for one to apply for a policy, one of the conditions was HIV and AIDS testing. And I was at the policy site, I was told that I must go and do the test. I went to a certain doctor in the CBD in town, and I took blood, and they said I must come back in 2 weeks' time. And in 2 weeks' time, they gave me the result, and out of a blue, I was told that I have AIDS.
After receiving the news that he tested positive, he was later retrenched by his employer.
And I had to go back because I had the application forms. I had to go back with the application forms to my employer. So when I get there, I informed them, and my employer was not happy with that. And he then retrenched me.
According to Pleasure, around the late 90s, there wasn't much information with regards to HIV, and this led him to seek information before disclosing to his family, as he also thought he was going to die.
Before I disclosed I joined TAC, it was not easy because after receiving the result, I could not even talk to people. Everything that was in my mind, it was my funeral. I could see my funeral when I closed my eyes. And at least TAC took me through the processes of how best can you disclose? What is the best time and the best way of disclosing?
According to Pleasure, there wasn't any medication in South Africa in the 90s. He only started taking treatment in 2013 and also contracted TB.
For 2013, that's when my CD4 count dropped, because before 1999 up until year 2013, I was not taking any medication. So 2013, that's when I started taking medication.
Both Pleasure and Ivy are HIV activists. They encourage those living with HIV to never stop taking treatment, as they would like to see a HIV-free generation.
If you are talking about taking or encouraging people to be on treatment and we are not on treatment, it is not easy. It is easy for somebody who's taking treatment to encourage people because they know what is happening with treatment.
All right, so let's talk about the subject of HIV and AIDS, and it's a great pleasure to welcome our special guest for today. First up is Professor Ameena Goga, who's an interim director of the South African South African Research Council's HIV Research Prevention Unit. It's a long one, isn't it?
Yes.
Welcome to the talk.
Very long.
All right.
Thank you
and
so
then, of
much.
course, we have Dr. Ben Montwedi, who's the acting chief director in the HIV and TB Services Unit from the Gauteng Department of Health. Welcome to Health Talk, Dr.
Thank you so much. Good morning.
All right. Last but not least is Dr. Sandile Buthelezi, who's the CEO of the South African National AIDS Council. Welcome to Health Talk, Dr.
Yes, good morning, Doc, and good morning to the viewers.
All right. So let's start with you, Prof.
Sure.
And we want to start with a very basic question, just in case somebody out there doesn't quite know what we're talking about. What is HIV and what is the difference between HIV and AIDS?
Okay. So HIV stands for human immunodeficiency virus, and it's a virus. It's a slow-growing virus. And when someone gets infected with the virus, then we say that they are HIV infected, or we say nowadays the better terminology is that the person is living with HIV. So you could have a woman or a child living with HIV. And if that virus is not treated in the body, if there's no medication, if the person gets sicker, the virus starts infecting the cells, the immune cells in the body. And so it starts killing off these immune cells. And if there's no treatment, then the immune system starts deteriorating, and then you end up with AIDS, which is acquired immunodeficiency syndrome. And by that time, you're quite sick. So there's a big difference between being HIV infected and having AIDS. And one can really live a very healthy life if you're HIV infected.
So
you
what are
don't
we
have
saying?
to progress to AIDS.
All right. So let's just get all of these basic questions out the way.
Sure.
So we say HIV, is it curable or not curable? Or controllable?
It's controllable.
Right.
At the moment, there's a cure agenda when it comes to research.
Yeah.
There have been the odd case of somebody having HIV, getting treatment, and after a few months, the virus being not detectable after they've stopped treatment. So there's a cure research agenda.
Yeah.
But at the moment, it's treatable and controllable, not curable.
Okay. I want us to start talking about, the prevalence and the incidence and so on. But before we come to the current, picture, let's start with you, Dr. Buthelezi. Let's try and look back a little bit over the years. Some people have said that, we've made some progress. In fact, the Deputy President was quoted as saying, we've made some progress in the fight against HIV and AIDS. Perhaps just take us back a few years and take us along and kind of map, the successes that we've made, insofar as HIV and AIDS is concerned.
Yes, thank you very much, Doc, and thank you to the professor for giving us that good explanation.
Right.
Well, South Africa, we come from very far, and I'm one of the lucky people. I don't know whether it's lucky because I've been part of the fight since the year 2000, when I still worked for KwaZulu-Natal. So we come from very far, but we all know that HIV has been decimating our population. Until at least we came to actually 2004, when we actually had to start our treatment program. But prior to that, people were really being managed conservatively and trying to look after the symptoms, but there were no antiretrovirals available, except that from 2001 we started with a single-dose nevirapine for the prevention of mother-to-child transmission. So we started our then program in 2004, and we built up on it. But I must say that a huge policy decision came in 2009. On the 1st of December, which is why this World AIDS Day in 2019 was not just like any other world
It was
day.
a very
It was a
significant
decade.
one. Yeah.
It was a decade since those drastic changes that were announced on the 1st of December 2009, where we actually changed the CD4 count threshold to 350, and also started treating people who have co-infection of TB and HIV, and also, but more critical is that at that time government said all public health facilities should now offer treatment, not only the accredited facilities, but also that the children were to be treated irrespective of their CD4 count. Fast forward from then, we came to 2015 where we moved our threshold to actually 500. Then fast forward 2016, then in September, we then moved to what we call universal test and treat, where we now treat all the people irrespective of their CD4 count. So a positive HIV test qualifies you for treatment. What have we seen from 2010? Of course, we've seen some good progress. Let me start. Of course, the more people you treat, your prevalence is not going to go down, because that's a pool of people who are HIV positive. But it's also good. It's telling you that not many people are dying. Because you should be worried when you have more people getting infected, and then but your prevalence decreases. It means that there are a lot of people dying, which is a problem. Yeah. So from 2010, in terms of deaths, what we've seen that we've actually decreased deaths by at least 53%. Because that's quite huge. We're sitting at around 140,000, we're around 70,000 in terms of our Tembisa model. New infections, we've decreased them.
That's exactly where I want us to come to, because you've painted this very beautiful picture in terms of the progress that we've made, and of course the other thing is that the life expectancy overall has improved.
Yes.
But we have challenges, Dr. Motaung. What are the current challenges we're facing with HIV?
Key to the challenges would be, I think we've become a victim of our own successes. When the policy changed, as Dr. Patel put it very well, when it changed, read the CD4 count. We had then lots of people who were tested. CD4 count was then done. You'd be told, my CD4 count is above 500. You would then, previous years, you would not necessarily qualify to be on ARVs, but you then be taught how to live healthily, eat well, exercise. Your CD4 count would even go up. Now with the latest policy changes, now that CD4 count is off the window. Now we're sitting with the challenge of, re-employing what we call welcome back campaign, making them aware, those whose CD4 count has been high over the years and living healthier, we need to call them back. Because I think the biggest risk we're facing is that if now your CD4 count then continues to decline, more infections come on board. It then becomes costly for the department.
In terms of new infections, I mean, he's talking about more infections, and that's exactly where the major problem is, new infections. Tell us a little bit about the incidence.
So it's very difficult to measure incidence, and at the moment we know that prevalence is sitting at around 20%. It's estimated that there are about 240,000 new infections every year. And the risk group for new infections are quite well defined. It's really younger people, so it's the 15 to 25-year age group, still sex workers, still men who have sex with men. And so those are really the target populations that we need to start doing more work with. There are several risk factors for new infections.
Yeah, before we get to risk factors, you're from Gauteng Health. I mean, do we see any differences amongst provinces? I mean, Dr. Buteles, you started talking about, KZN. What's the picture like in Gauteng as compared to other provinces?
Gauteng and KZN would almost be the same. I mean, Gauteng contributes at least 25%, to the whole, HIV, issues around the country, and I think more than anything else, our biggest challenge in Gauteng would be the in-migration. That doesn't happen in another province. Got huge in-migration where now you then test people when you are planning to put them on treatment, especially those who feel, no, I still have to go to, think thoroughly about it. Before you know it, that person has gone back to his province or even outside the country. I think that those would be the huge challenge, the mobility of our clients. Even those that we've started putting on treatment, when now follow-up is due, we then at times battle to locate them.
All right, okay. I think this is a good time to go for a quick break. When we come back, we try and understand the risk factors for transmission of this virus. Please stay with us.
This is where we take a look inside the world of media, analysing the trends, the issues and the reporting of some of the week's top stories.
One of the things that we are seeing across the globe, people are consuming news and living their lives with their mobile devices.
The evolution of journalism is to use the same skills, the same ethics, the same values, but to cater to different audiences, because it's not the same people.
There is a lot of debate in this industry today whether the future is about digital paid content. Will there be a market for users to pay for digital content? And we see that in Africa it's a challenge.
People will go, pay for a newspaper, take it away. Why won't they pay for it online?
In the initial stages of shifting from print to online, we created the impression that what people were paying for was the paper. And so people are very reluctant to pay for the journalism, and good journalism is very expensive.
Watch Media Monitor Sundays at 9 a.m.
They need to step up and take responsibility.
He believes that these banks were actually enablers of state capture.
I met senior directors of HSBC and Standard Chartered. I found a great reluctance from both of them.
Reverend Frank Chikane was very actively involved in calling out state capture.
The Guptas would tell you, if you don't do what we want by Wednesday, you won't be a Director General.
The murder case has implicated some senior public servants. Tell us more.
Indeed, this case has gained more traction, as we see, after an auditor has testified on the financial flows between Siemens and Bagili.
Department of Community Safety, Security and Liaison and the Department of Health had promised that it will strengthen security in all hospitals in the province. That has not yielded any positive results.
Welcome back. We're talking HIV and AIDS with our guests here. We have Professor Ameena Goga from the South African Medical Research Council. We have Dr. Buthelezi, CEO of SANAC. And then we're joined by another special guest, Ntimbwe Mpamba, who's somebody living with HIV who's going to share his story with us. But before that, there's just a few tweets that we just want to go through. Moeketsi says, it's World HIV Day and communities do make the difference. How can you make a difference? Know your status. Don't stigmatize or segregate people living with HIV. Encourage your family and friends to do their HIV test. So true. Brad Fraser says, today I remember not the celebrities and high-profile people who died of AIDS, but rather all of those people who died alone, shunned by friends, family and medical professionals too hateful, indifferent or cowardly to do their jobs. You are not forgotten by me. And all right. So before we start our conversation, I believe that we have a call on the line. Dudu from Vosloorus. Dudu, welcome. Dudu, are you there?
Yes, I'm there. Thank you very much.
Hi, Dudu. Yeah, go ahead.
My question is directed to the lady there.
Yes.
She has mentioned that HIV is currently treatable, but it's not totally curable.
Yes.
So will it be curable or will it remain treatable?
All right. Interesting question. Thank you so much for the question. Very academic question there.
Very interesting question.
Yeah.
So when we say that HIV is treatable, we mean that there are various drugs available, and usually nowadays we use them in triple combinations, so 3 drugs. And our aim is to use the drug so that we drive the viral load down really low.
Yeah.
And Dudu, you may have heard of terms being used such as LDL, so lower than the detectable level that comes up on a lab test. And that says that the laboratory is having difficulty finding HIV in your blood. Mm-hmm. And that's where we want to be.
Right.
We want people to have LDL or viral load less than 50 copies per mole, ideally.
Yeah.
But HIV is really clever. It has these reservoirs that it develops in the body. And those reservoirs sit there, and we can't really find the virus in the blood. And so in order for HIV to be curable, what we want to do is get rid of all those reservoirs in the body. And that's where we are with research to do. We're trying to see, is it that if we start treatment very early, as soon as possible after diagnosis, that we can prevent the formation of these reservoirs in the body? Is it that if we use new modalities, such as vaccines, such as monoclonal antibodies, that we can start mopping up, almost eating up all these viruses in the reservoirs in order to achieve a cure? So at this point in time, we're not there. We're working to get there. But at the moment, HIV is treatable, it's controllable, we can drive the viral load really low. But at the moment, we can't get rid of the reservoirs. And so it's not curable.
We've made reasonable progress.
We've made loads of progress, yes. And there are vaccine trials going on, there are antibody trials going on. So we really have made progress. And the cure agenda is strong.
All right. So HIV and AIDS has had an impact, at different levels, with different people that have been living with the virus. And to share the personal story with us, today we welcome Ndimbwe Mpamba. Ndimbwe, welcome to Health Talk.
Thank you. And to the viewers, I'm still alive and still going strong.
Right, you're still alive. Tell us a little bit about yourself.
Oh,
You've been living with HIV for quite some time now.
Yes, 36 in 8 days. I'm going to clock 37.
Right.
Yeah,
Tell us about it. Where did it start and how's been your journey like with HIV and AIDS?
Well, I was born in the year 1982 as a bouncing baby boy.
Right.
And at the age of 4, I became a Vienna, a very, very thin child.
Yeah.
And the community got concerned to say, but this person was big, now they are small. So
at the age of 4, you said?
At the age of 4.
Right.
So my mother put me under medicine, like these vitamins.
Yeah.
But they came in sweet packets.
Yeah.
Not in those normal sachets for medicated.
Right.
Because she found which if they came in medicine, I would start asking questions. But when you find that some are sweet, some are bitter, you start varying, say, but why is one not the other?
Right.
I said a lemon and an orange have got different flavors, yet they're all fruits.
Right.
So I was found a way to say, in whatever question I had, she always had an answer to it. And the time when my father got to be promoted to say, come to South Africa, I gave away my whole entire life to say, wow, I'm going to greener pastures. The whole world knew to say, I'm going overseas, not knowing to just a stone throw away.
Yeah.
So I got to enjoy a new environment, but I didn't know that my health was getting more affected. Because
so you came to South Africa in 1986?
92.
92, okay.
Yes.
Right.
But by then I would have so many diseases, but my mother would find a way of cover them, say, they'll come, they'll go. They'll come, they'll go. So getting sick was something that I got used to, and the hospital became my holiday home. I would rather be in the hospital because I would choose the food that I would eat. Then at home I would say, everything that comes, you eat.
So you've been on medication for quite a while. Starting, from a young age.
I'm the one that
and how did it feel, playing around with your friends? Yeah?
Yeah, I can smell medicine the same way a woman smells food, like in the kitchen. I'm the medicine guy. I'll tell you what is what just by smell.
Right.
And I know the effect of it if you don't take it in such a way.
Right.
Like antibiotics, you don't take them on an empty stomach because they give you a running stomach.
Right.
So that I've got to become the medical expert without being educated for it, because I am the living proof of what it took to actually learn the hard way.
Right. But all these years you've been on medication and you're living a perfectly good life and you're perfect.
Believe me, I've actually taken more beatings than recovery, because when I got to say, finally I've got my space, I never knew that it was actually the beginning of the worst.
Right. Before, I don't want us to run out of time before we talk about risk factors for transmission. And firstly, let's just talk about transmission, because his story is quite relevant. How is HIV transmitted?
Yeah. So there are various ways that HIV can be transmitted, and it can be transmitted in sexual relationships, so men to men, women to women, or man to women. And then just looking at your story, probably transmission from mother to child. So we call it vertical transmission. It goes down from one generation to another. We call it vertical transmission of HIV. And there have been many babies in South Africa born with HIV that way, but we've seen tremendous success over the last few years. And just linking with your question about risk factors, the main risk factor for transmission is having a high viral load. And at the moment, there's a huge campaign. There's a slogan out there, U equals U. Undetectable equals untransmissible. It's very important. So if you don't find a viral load in the blood, if it's undetectable, the chances of transmitting that virus are very low.
Dr. Buthelezi, I mean, we've spoke earlier about, this vulnerable population and where we seem to be having a major problem. Females, young females between the ages of 15 and 24. What are the risk factors there? What explains this high level of incidence?
Yeah, the big issue we have in the young girls, firstly, their vulnerability lies on the fact that they get involved with older people. They are therefore unable to negotiate the use of a condom. It's a big issue, but socioeconomic factors. But the most critical one is not using the protection. For us is very critical, and we're looking into those areas. But then the other issue is the issue of the gender-based violence. I mean, the rapes. I mean, if you are on the media now, you can't finish watching a bulletin without hearing either a femicide, a rape, or the issues. I mean, we've just really seen the statistics from the police on the whole issues of gender-based violence, which is why the president is taking that head on now in actually addressing those matters. So there's quite a number of factors that we need to address, but they are actually addressable if we come together, and they cannot be addressed by the Department of Health or by government only. It needs a broader community to work together to address those factors.
Okay, fine. And Dimba, I'd like to speak to you a little longer, but unfortunately we don't have a lot of time. Okay. 20 seconds.
Yes.
Just a final message to our viewers.
Oh, I got to rise above the virus because I chose to love the virus.
Right.
And I've created a boot camp called the ABC Boot Camp 2017 strategy.
Right.
It will teach you the value of what was spoken. Say, if you don't have the right nutrition, you won't find the right mindset. You won't understand the value of medication to know how to exercise and find your support system.
Wonderful.
And it's actually right here, and it will soon be on the shelves of every bookstore.
We're gonna try and share that with with our viewers shortly. But thank you so much for your time.
No, it's always a pleasure.
I believe that we have two last tweets that we need to go through. Your next boyfriend says one of the early signs of HIV includes refusing to go for HIV test. Interesting way of putting it. And Cecile says, I have finally got the confidence to go and do an HIV test. Good on you, Cecile. All right, time for a quick break, and when we come back, we'll continue our discussion on HIV and AIDS. Please stay with us.
Here's a minister who says, I'm working on some sort of plan.
There's no way that we can agree to pay workers less wages. There's no way we can agree to domestic workers being paid less than what they currently get. We can't agree to farm workers being paid even lower than the slave wages they earn right now.
What is the role of lawyers in the fight against corruption in the country?
We've seen lawyers who knowingly that this client or who would have a reasonable apprehension that my client could be paying me from proceeds of the crime. I think it's about time that we legislation somehow considers how to discourage that type of conduct by lawyers themselves.
Where are the gaps as a person who has thoroughly interrogated the 4IR space and how it will have impacts on the country?
One of the unfortunate consequence of the fourth industrial revolution is the possibility of increase in inequality.
Okay, welcome back, and thank you so much for staying with us. If you've just joined us, we're talking HIV and AIDS, and we will be focusing on prevention. And we're now joined by another set of guests, special guest, Dr. Ben Montwedi, who's an acting, we've always had Dr. Ben Montwedi, who's acting chief director from HIV AIDS, HIV and TB from Gauteng Health. This is Dr. Moeketsi Mathe, who's an HIV specialist and also lecturer at Wits University in the Department of Family Medicine. Welcome to Health Talk, Dr. Mathe.
Thank you for having me.
All right. And another special guest is somebody that we've had so many years ago on this program, Meisie Motaung, and she's been living with HIV for many, many years. and she's made quite good progress, in fact, and she's involved in a lot of advocacy around this. And welcome back, Meisie.
Thank you so much for having me, Doc.
All right, okay. Perhaps let's start with you, Dr. Mathe. We're talking prevention. We've covered all of these issues around, risk factors for transmission and what have you. But simply, how can HIV be prevented?
It's a good question. And fortunately for us, government has a basket it's got a basket of care that one can use. But I think it starts with the individual.
Right.
And depending on which age group you speak to, the prevention methodology changes. Often when I speak to young people in university, and I'd ask them, in your bag right now, do you have a condom? They say, no, but doc, why do I need to have a condom? I mean, I'm not going to have sex. Well, okay, when is the last time you planned sex? With young people at varsity, it happens spontaneously. The point is, if it's going to happen spontaneously, you ought to be prepared for it.
Right.
Now, someone like, no, but if somebody finds condoms in my bag, what are they going to think? My view is they're going to think that you are responsible and are protecting yourself, enjoying the natural biology, while making sure that, one, you prevent HIV transmission, other STIs, and you are preventing unwanted pregnancies.
Let's stay on the condoms for a while and talk to Dr. Motaung. Condoms. Are they now freely available?
Yes, Dr. Motaung, condoms are freely available. And I think you'll recall some few years back, the then Deputy President, but now the current President of the country, launched even what we call now the scented condoms. There's been an outcry from civil society over the years of our previous condoms that were almost dull in terms of smell.
I guess the question is, how effective are condoms in preventing HIV and AIDS?
When used, consistently and correctly, I think that's the key thing. Because as one starts a relationship, you begin to use a condom. As and when the relationship appears to mature, then the usage becomes erratic.
Right.
I think when used correctly and consistent, I think that's the key word.
There was a time when there was a concern that, even though we're making these condoms freely available, it appears as though that, people, especially youth, aren't actually using these condoms. And there's also the question of female condoms. One of the crew members actually asked the question, how is it that we only learn about male condoms and we don't in fact see any of these female condoms being distributed widely?
Condoms, both male and female condoms, are being distributed widely. By the way, it's safe to say that there's already an outcry from civil society to say, let's even stop branding them male and female.
Right.
What about the LGBTIs? Who don't fall in the category whether it's male or female condoms? They are being distributed. I think there's also has got to be, extensive marketing re the female condoms. But they are being distributed, both male and female condoms.
Okay. Meisie, we spoke to you a couple of years ago, and you've had quite an interesting journey, and there's quite a lot of good work that you're doing. Perhaps just take us through your journey until now.
It was 2004 when I got raped and got infected with HIV. And by that time, the ARVs were so scarce to get. So I was supposed to start my ARVs 2005, the 5th of May. Unfortunately, February, I was diagnosed with pulmonary TB. Then I had to take the TB treatment before the ARVs. Then May, it was a combination of ARVs and the TB treatment. The following year, I got diagnosed with cervical cancer. After that year, then it was the shingles, my whole entire body. But the most amazing thing is that after being diagnosed with HIV, my CD4 count was very low in a way that I was supposed to be maybe bedridden because it was 27. And the viral load was extremely high. So it was so difficult for my body to accept it. So, but I managed to pull through because hence, our government is playing a major role in ensuring that it reduces and helps us at the same time to take care of ourselves. So,
and despite all those health challenges, I mean, you've been in good health generally.
I'm in good health. You know me being like this, Doc, as I can say. I've never changed anyway because I'm taking my one pill every evening. So that is part of my friend, and the friend that will never ever betray me.
Right. We're going to talk about that one pill a little later on. But let's take Chibasa on the line from Venda. Chibasa, welcome.
Hello.
Hello, Chibasa.
Hello.
Yes, go ahead, Chibasa. Welcome.
I'm asking the question that if after 6 months taking that treatment,
yes,
when you go again to take the blood and they told you that they can't see nothing in your blood,
right,
what must I do? I continue to drink that ARV.
Okay.
Tablet.
Beautiful question. Let me give it to Dr. Mathe. Somebody goes, there, undetectable virus. Should I now stop taking treatment because there's no virus?
I think if you go to the clinic, they take your blood and they say that virus is undetectable, you should celebrate because it means you're doing well.
Right.
The fact that we can't find the virus in the blood means the virus isn't doing damage to your body.
Right.
And that's a cause for celebration. In fact, that's the point of taking treatment.
Right.
The point of taking ARVs is to suppress the virus to what we call less than detectable limit. So it means when we look for it in the blood, we don't see it.
Yeah.
Just be aware, not seeing it doesn't mean it's not there. It means that it's at such a low level that our test can't pick it up. And that means that you go back to normal health. You can basically live a normal and healthy life. So you should absolutely celebrate it.
Yeah, exactly. But the important message is that you don't stop treatment.
Exactly.
Absolutely not.
You carry on with the treatment.
Oh, yes.
Let's carry on the subject of prevention. And perhaps let's come to you, Dr. Ndlovu. We've spoken a little bit about, the issue of condoms and so on. Any other methods that we're doing to try and, prevent the spread?
There's also another strategy that we've developed as a department, especially for your sex worker population. Now it has moved to your adolescent girls and young women. It's going now to what we call your serodiscordant couples, called pre-exposure prophylaxis.
Right.
PrEP.
Yeah.
It is a very, important modality that, where we then, test, individuals and those who are found or who know themselves to have substantial risk of contracting HIV.
Yeah.
Be it your sex workers, adolescent girls and young women. I think we spoke about earlier on that in as much as incidence has gone down, it's still high around those age groups.
Yeah.
They get counseled properly, where they get given that pill. It's also a combined pill. It's 2 pills in one, where they then take that pill through and through for as long as they are on that, that substantial risk of contracting HIV.
Yeah. Meisie, one of the ways that people can, in fact, the only way that anybody can know that, he or she has, the virus is if the person tests. Just tell us a little bit about the work that you do in raising awareness, encouraging people to test, and so on.
I always get invites to correctional services, especially giving advices to the offenders, the government departments, schools, even churches, where I educate people about how to take care of themselves and making sure that they don't stigmatize and discriminate one another, because that is the major problem that our society is facing, especially realizing that you are HIV and you don't have support. So that's how I educate. The correctional service, that's where we have high rate of HIV inside the cells. So I'm educating them as to how to take care of themselves and work collectively with the nurses inside the cells.
Do you find there's still lots of, the issue around myths and, misperceptions around HIV?
Yes, I think so. And at the same time, people believe that HIV is no longer killing people because you always use condom. And they forget that when you consume alcohol, that's where you forget that even condom is in existence. Take, for example, most of the institutions, higher level institutions, is next to where they sell alcohol. And most of the girls or students, they go to the shebins, get alcohol, forgets about education. And after being drunk, that's where they forget that a condom is in existence. They realize in the morning that, I didn't use my condom. So high rate of HIV is still a taboo, especially in tertiary institution.
Maybe Dr. Mathe would respond to that. But let's take Boitumelo on the line from Soweto. Boitumelo, welcome.
Hi, how are you?
We're good. How are you, Boitumelo?
I'm great. I'd just like to know something here.
Yeah.
I gave birth to a very bouncy, healthy baby last year,
Right.
and I'm HIV positive and I'm not on ARVs.
Okay.
Can the doctors try and explain this to me? How is that possible? Because I was told, like, where to get off when I'm saying I'm not getting on medication. I am going to carry this baby and I'm going to give birth to a negative baby.
Let's just get this clear. Have you given birth to your baby already?
Yes.
Okay.
And my baby's 1 year, 3 months now.
Was the baby tested?
Still test HIV negative.
All right. Okay.
And I was diagnosed in 2014.
Oh, I see. All right. Okay. Well, perhaps let's get an opinion from Dr. Mathe.
So, firstly, I think we should all be very grateful that the baby came out HIV negative. I mean, we always, whenever somebody's pregnant, you want a great outcome, and the great outcome is a healthy baby. So I think we should be happy about that. I think as to whether she should take treatment or not. So, one, let's address. Not knowing the case fully, I suspect the reason the baby came out HIV negative, despite mom not being on treatment, was because mom probably has a relatively low viral load.
Yeah.
Because the determinant of whether...
Can I, and I'm so sorry to interrupt you. Can I suggest that, because we're going to be talking treatment in the next segment,
Okay.
We'll take that up, okay?
All right.
But for now, I really would like to say thank you so much, Meisie, for joining us.
My pleasure. Thank you so much.
We can only wish you well going forward with your work.
Thank you
All
so
right.
much.
We have one last tweet before we go on a break, and it's from Abram. It says, HIV is still a health disaster. Go for frequent checkups. Always insist on condom use. Encourage your partner to go for regular tests. Ladies can also arm themselves with condoms. No harm. Discourage teenagers from early unsafe sex. Remember, AIDS kills. Okay, it's on that note that we go for a quick break. When we come back, we'll wrap up our discussion on HIV and AIDS and talk about treatment. Don't go anywhere.
Finance Minister speaking last year was quite clear that, one, he doesn't want a constant bailout of state-owned enterprises, including SAA. And then he also said there's no reason for SAA and we can get rid of it.
The one that people are talking about is the issue of privatization, but I don't think that privatization is within the horizon at the moment. But what I can say is the liberalization of the aviation industry may be on the horizon.
Talk to us about the share that the continent gets as compared to the rest of the world.
$1.85 trillion globally, 2.5% of that went into Africa in 2018. For us, the number one most critical issue in the energy industry of Africa is investment.
It's time for us to be real stewards of our resources.
Alicia, how old are you?
I'm 10.
You are 10 and you are an author.
Yes. Well, my mom was the one who inspired me to write this book. Nothing is impossible.
Got him onto a 150, started racing, and within 8 months he was bringing home trophies.
Wow, that's incredible. You young man are going places.
It's one of the most cultivated regions in terms of content, and the
Welcome back. We're talking HIV and AIDS, and now we're focusing on treatment. And I want to start with Dr. Mathe. I cut you short in the last segment. You wanted to just wrap up, that response to that caller?
Yes. So the thing that one of the biggest determinants of whether somebody infects the next person or not, or whether a mom infects a child, is the viral load.
Yeah.
Viral load refers to the amount of blood, the amount of virus in 1 milliliter of blood. So if we say your viral load is 1,000 copies, it means in each milliliter of your blood there's 1,000 viruses. Right. So that's the determinant, and that also explains your discordant couple. So if the one partner is negative, the other one's positive, but the positive partner's viral load is very low, the risk of them passing HIV on to their negative partner is extremely low.
Right.
Ditto if and that's the point of treatment. The point of treatment is to suppress your virus, because if the virus is suppressed, you can't pass it on.
But talk about treatment. Let's just talk about the basic principles of treatment for HIV and AIDS.
So HIV treatment is always 3 drugs
right.
as a starting point. When I say 3 drugs, I don't necessarily mean 3 pills. It's got to be 3 compounds. Now, we have what's called a fixed dose combination available. It's a single pill with 3 compounds in it.
Yeah.
What we're using before, what was recently announced by the minister, was a combination called TEE, which is tenofovir, emtricitabine, and efavirenz. We've just launched a new regimen which contains tenofovir, lamivudine, and dolutegravir.
Yeah.
They're both very good drugs. TEE is good. There's nothing wrong with it. It does a very good job. It's just that the efavirenz part has got its problems, and the dolutegravir is better.
Yeah.
So it's a little bit like if you're driving a Toyota Corolla, it takes you where you need to go, but you now get a new job, you buy a 3 Series. They're both cars, they both get you there, but just one is better than the other.
Right.
And the dolutegravir is better than efavirenz. Efavirenz is still good, nothing wrong with it.
Right. Let's perhaps understand, from a broader perspective now, in terms of rollout of, ARVs and so on. Obviously, it's more convenient to take 1 pill as opposed to 3. But just take us through the principles around the rollout and making drugs available to everybody.
Yeah, I think for us in the public health space, we need to ensure that when we introduce any drug, it must be available to everyone, not only to the select. So we need to have very good procurement and supply chain systems, but then ensure that we don't run out of drugs, but ensure that we have the money to buy the drugs. One nice thing about South Africa is that we procure our own drugs. We don't actually depend on donors to actually buy drugs for us. So those are the basic principles. For example, with the new drug, we're starting to roll out in 5 provinces. But we want to ensure that by the end of February, all the provinces are actually there. But the other critical aspect is that we've got healthcare workers who are properly trained to actually administer those drugs and deal with the issues that are associated with those drugs. Those are the broader principles that we actually, which is why our government was actually quite involved in ensuring that we get down the price of drugs so that we're able to procure them, the fiscals can afford, but everyone can actually have access to the drugs.
How well are you managing the distribution? We've had in the recent past, issues around stockouts and so on. People go to a facility expecting to get their medication, and suddenly they told, come next week or something like that, or go somewhere else.
Things have changed, Dr. They've changed for better in that we do have a system now it's an electronic system called the tier.net system, where all patients who are receiving ARVs get captured on the system. So the facility, when the day ends, you'd know that this facility today has got 500 patients who are on ARVs. When you then order, moving forward, you order your 500 and you put in a buffer of 10% within it. Things have improved. Currently in Gauteng, we're currently sitting with more than 1 million patients on antiretroviral drugs. And all our health facilities, we're talking about the 372 clinics and 37 odd hospitals. All of them, are offering, HIV services, and all of them are well stocked up, on the drugs. In terms of this very new drug, our depots, have got this drug because we do have projections in terms of the department as to how many more how many initiations per month, per day we make, and then we make, sufficient projections.
Okay. Talk about test and treat. How well are we doing in getting people to test so that we start treatment as early as possible?
Yeah, we've reached the first 90 in terms of the testing aspect. But our problem is that we're not putting as many people on treatment. But the doctor spoke about the Welcome Back campaign, where we're actually working with the PLHIV sector, the sector of people living with HIV, to go and get those people that we tested, because they are part of these 90. We've tested them, but at that time, that was before UTT, Universal Test and Treat. I think we're doing well, which is why then the president actually gave us a huge order that by December 2020, let's go out and get the additional 2 million people on treatment, because they are there, they are positive, but they are not being treated. And the problem is that if they are not being treated, they've got a high viral load, so they are probably continuing passing on the virus and infecting the other people.
Those that are being treated, how can we encourage, how can we ensure that they continue taking the treatment? We spoke earlier about issues around people wondering whether to continue or not to continue.
I think most important, as healthcare workers, people should be able to talk to us. I think there was a time where people took treatment because they had a fear of death, and they were willing to live through side effects. With HIV being so normalized and people understand it's a chronic disease, they need to be able to come to a doctor, when I take this pill, this happens to me. And they need to be able to talk to us, and we need to be able to respond to that. Because pills only work if you swallow them. And if somebody knows, if I swallow this, it's going to do this to me, they're not going to take it. So it's really up to us as healthcare professionals to create the space for patients to talk to us openly about any problem they're having with medication. Because whatever problem they have, I can almost guarantee them we can solve it.
Okay. Gentlemen, this has been such an insightful discussion, but unfortunately all good things come to an end at some point. And I want to thank you so much for your contribution, and wish you well over the festive season. Of course, hopefully we'll meet again in the new year and continue talking about this very important subject, HIV and AIDS. And you guys at home, thank you so much for watching. Please remember that this is perhaps the last show we're going to have live on our SABC 2 channel, but on the other channel, news channel, we will continue showing our shows on Saturdays. But until next time, please do take care.